Thanks, Joe. I think people might remember we sent every practice got a copy of the AF pathway last year. But if you want some more, it is available on the SCN network, and we can always give you more copies. But it's a very good document. I helped, like Joe and Debbie, write it. So, we tried very much to make it primary care, good for primary care. So, thanks very much, Joe. Jenny's going to talk to us now.
I think I'm going to do the draw while I settle.
Am I going to do the draw?
No, not yet. Oh, not.
I'm not doing the draw.
We're not doing the draw.
Would you like a joke? What would you like me to do? No, I can't do a joke. Let me just tell you about Jenny. Jenny is basically from a company called Primus, yes?
Yes, that's right, yeah.
And basically Primus is a company which is still University of Nottingham.
Yes.
The best university probably in the United Kingdom. You can have a guess which medical school I went to. Jenny's company has been behind GRASP AF. And as I say, one of the things in the LES is to try and encourage practices to use the GRASP data and also to upload it so that we can see at CCG how we're all doing, and also to offer to support practices who are clearly struggling. So Jenny's going to talk about how we're going to do that, and over to you. Is that okay?
Yes, thank you very much.
Thanks very much.
The company's called Primus. We're an organisation, really, and the reason I don't say we're a company is that we are based at the University of Nottingham. We are a business unit. We used to be fully NHS funded, and you may have heard of us. We've been around about 17 years now, working with practices and primary care data. We love data. That's what we do. So we used to have Primus facilitators out in PCTs who used to support practices. Now, unfortunately, because NHS funds the way they are, we are now self-sufficient. But the fact that we are a business, and we're still in the university, the fact that we're a business unit of the university actually gives some assurances to you, hopefully. We are governed by them and their IG processes, and we have to abide to a lot of their rules because we are using their reputation at the end of the day. So it's a reciprocal arrangement, really. But we're not about making money. As long as we're within Division of Primary Care, so long as we're doing work that is aligned to the core principles of the university and the School of Medicine, they're happy for us to continue to be a partner. So GRASP AF is one of a suite of tools that it's actually been delivered and owned by NHS England. It's one of many tools that we develop nationally. So you may have heard of some of the others. They're using this GRASP branding now for some other clinical areas. GRASP AF was the first. But they've got others, GRASP COPD, heart failure, and now GRASP fever is one of the latest, which is looking about sepsis, really, feverish illness in children under 5. The GRASP AF has been around a few years, as I probably just said, but it came from the West Yorkshire Cardiovascular Network and the Leeds Arrhythmia team in around about 2009. So I did speak to one of the GPs earlier who said they'd had a go in the past. And it still hasn't really changed much since then. We keep it updated in line with NICE guidance, so it's been released a few times to represent CHADS VASC, for example. And it's managed by Sustainable Improvement Team at NHS England. I won't go on about this epidemiological study because we've had a lot of the research and background and facts and figures so far. But basically some of those members of that team took part in this study using the GRASP AF tool, and they found similar things to what's been discussed already. So what is GRASP AF? Well, it's a tool for practices to use for you to identify some of these patients that have been talked about this evening. So it will help you case find, first and foremost. It will help you find patients who have probably got AF or have possibly got AF but don't have an AF diagnosis. And I'll show you some of these tools shortly. That's the case finder side. And then the care management side is looking at those patients who already have a diagnosis of AF or atrial flutter. And then it stratifies their stroke risk. So it does the CHADS score and the CHADS VASC score. Now, you mentioned before that CHADS VASC is in QOF, so it's actually quite well recorded now, but in previous years, it wasn't so well coded on the clinical system. And that was a key feature of this tool, was that it did that calculation for you, and then you could go back and enter it onto the clinical system. So once it's found those patients, those at high risk of stroke or at medium risk of stroke even, it looks at anticoagulant therapy. Are they on one? What contraindications have been recorded? Has the patient declined? And then it provides you a practice level view of your results and a patient data sheet underneath for you to drill down and see who these patients are and have a look at all the related AF data in one place. It's real-time data. You're all EMIS Web, so what we know with EMIS Web is because we use MyQuest, it has to run overnight. So there is a time delay on that side of things, but other than that, it's as fresh as the day before you run it. We also develop and maintain a chart online toolkit for GRASP AF as part of this programme, so you can upload your data. Bruce has alluded to it already. Data goes from chart online then into this local dashboard that you saw some snippets of before. So unless you upload, it's not going to make it all the way through to that data set either. But it is aggregated information, and I'll give you some more assurances about that shortly. So what does it look like? This is the dashboard of the GRASP AF tool. I'm going to just now switch to the live demo. I'm hoping it works successfully. Yeah, oh no. Okay. So once you've run the queries and loaded your data, this is what you'll be presented with. So as I said before, we do CHADS and CHADS VASC score, so you can actually switch between the two scoring systems, and it will change the results on the dashboard there and then. Not so important now, most people do want CHADS VASC, but historically many areas were still using the CHADS scoring system. So looking at the top left, and we'll work our way over, and I'll just talk you through it. It gives you your practice population and then your AF prevalence within your practice. I think you've already mentioned, Debbie mentioned the AF prevalence being about 1.8%, and that's reflected here. And as you can see, the AF prevalence in this practice is increasing as the age band of the practice is increasing. So it goes up to around 12% in the over 85s. Then we're looking at the actual stroke risk profile. So your low risk, 0, CHADS VASC of 0, medium risk of 1, and then high risk, greater than 1. So here we have 86 patients with a CHADS VASC score of greater than 1. Going to the middle row, we have now a breakdown of all the risk factors that are used to generate those scores. So it actually gives you an idea of what your other disease areas are that are contributing to this risk. So you can see here clearly that hypertension is one of the key factors in increasing the stroke risk in these patients. Might be something you want to look at the same time. The most important thing potentially is this anticoagulant treatment graph in the middle here. So again, it's broken down by risk score, 0, 1, greater than 1. So the bottom row is really the one that you're going to focus on. And what it's showing is, if I can zoom in a little bit. There are 72 patients at high risk of stroke in this particular practice who aren't on an oral anticoagulant nor an antiplatelet. If there was some yellow blocks there, that would show there were patients on antiplatelet only. There aren't any in this example, but there are 2 patients who are on both anticoagulant and antiplatelet, 12 on anticoagulant. So the 72 really are the ones that we're interested in here. And it's those 72 that are used down here in the bottom, your shock factor, which is saying that based on these 72 patients and their current treatment regime, if nothing changes in this practice, it is expected that 3.7 strokes will occur in the next 12 months. And then just a little bit on the bottom row is really how many have got a CHADS VASC score actually coded on the clinical system. We would expect that to be higher now with it being within QAF. And how many have an AF review coded within the last 15 months. I must stress that this is a clinical decision-making aid. It's not here to do the work for you and tell you what you need to do. It's really designed to shine a light in the areas, and it can only be as reliable as the data that's on your clinical system. So, for example, stroke is one of the risk factors used to calculate CHADS VASC score, and we know that there are some areas where 30% of strokes recorded on the clinical system are generic. They say stroke NOS. We don't know what type of stroke it was. And in those cases, we have to presume it's ischemic for the purpose of calculating. But it's just to demonstrate that it's actually only as good as your coded information. So always just bear in mind, what is this data telling me? Is it really what I think it is, or do I need to investigate a little further? And another example is the AF review. You may have reviewed them but not entered that specific AF review recall code. This help button on the bottom is kind of hidden. I would recommend you use that when you're first looking at your data. It will take you to this document, which is a step-by-step of the results and what to do, what these charts are showing you, how you bring up your patient lists with all the screenshots within them. So if you've got a colour printer, even better, you print those off and have that next to you. Or take it home in preparation for doing it. So that's the dashboard for Grasp AF. We also have a classic view, so you'll see a hyperlink at the top, and that will take you just to a table that's giving you some of the actual figures. So it's just the same information presented in a different way. This is our tool, it's called Chart, and you may have used it for other things like IM&T DES a few years ago. We have a diabetes tool, we have lots of different tools, all using this same software. So once you've got to grips with this and the way it works and how it looks, it actually becomes very familiar. It's just the first time you might find it a bit difficult because you're not used to using it. We always have this summary view, so this is your practice level view, and then the data sheet on the top bar is where you get to your patient level data. So all of those patients that were picked up as part of the audit now appear here, 1 line per patient. You can see here patient identifiable data or pseudonymized data. I was talking before about uploading figures to Chart Online. We have built-in security here so that you can only upload when you've run the pseudonymized set, because we don't actually hold any patient level data and patient identifiable data at Primus. So just to see, we have some features built in, like preset filters, to help you try and get to these patients as quickly as possible. So you've looked at your results, you want to find these patients. So we have some preset. You're probably going to be interested in filter 3, which is your high-risk patients who aren't on an anticoagulant. This one will show you, first of all, those who don't have a contraindication. They have no reason why they're not on an anticoagulant. They have nothing in their record to suggest they're contraindicated, and they haven't got a recorded indication that they've declined medication. And you'll see they're all in red. So these are the ones you could possibly target first. The data sheet contains all the relevant fields that are used, anything that you might like to know while you're looking at these patients. So there is quite a bit of data there, and it can be quite overwhelming. And some of them have been collapsed down just to make it quicker to find patients that you want to look at. So just bear in mind that sometimes you have to click on the top to get to different bits of information. So we've got our 60 patients here, high risk of stroke, not on an anticoagulant, and no reason for not being on one. If you wanted to find the 72 that we saw on the dashboard who may have a contraindication recorded, you can simply filter this data sheet now to create any kind of list that you want. So it's Excel based, so you would go to the CHADS-VASC score column. Because it's moved over because I've opened that section up, here it is. So CHADS-VASC risk category, high risk, is what you would select from there. And then right at the end of the data sheet, we have anticoagulant status. And what you want to do is include anyone who isn't on an anticoagulant, so untick on anticoagulant. And there we have our 72 patients. In the bottom left corner, you'll see the number of patients that you're looking at. You can copy and paste these columns into your own spreadsheet and do extra work with them, whatever you need to do. Okay. Can I ask you, Bruce, how you've been getting on with reviewing your patients in your practice for the Grasp AF side of things? I mean, did you tend to focus on those with a contraindication?
We do it every quarter, and I look at them, and I start off by looking at the CHADS to high risk, not anything, and I go through. And
no reason for contraindication.
I go through them, and it's time consuming, but bit by bit, we are getting there, and I tend to leave little love messages to my colleagues to say when you next see this patient, do them. So, I mean, we're getting there. I mean, we are showing a progressive improvement. Yeah. We're not perfect, but,
it takes time to get the patients in, doesn't it?
We've probably said 20 or 30 people more now who are anticoagulated that were anticoagulated 12 months ago. Yeah. And that's probably 2 or 3 strokes that we saved. And, I feel good about that.
Yeah, definitely. Yeah.
So we just need to keep at it.
Yeah.
But you have to keep running it. Every quarter we do it. And in the LES now, we have actually said people, they have to run it. Yeah. Could you show how do you upload that?
I'll have to upload some pseudonymized data because, as I said, it's got a built-in feature to stop any patient identifiable data going. So I'll just load some pseudonymized. And what we would recommend is you run them both at the same time. So when you get asked, do you want identifiable or pseudonymized, say one and then repeat it and do the other one. Now, I know we've been having discussions with the CCG about helping you out with the technical side of installation and running, so you can actually get on with looking at the data. So there is some help coming. I don't know if Sheena's going to talk a little bit about that at the end. Sorry, I've got so much data here. pseudonymised. You can email that summary sheet as well if you wanted to send it to the CCG or just someone to look at, a colleague, and they can receive just that snapshot of the data. Now, because I've loaded that pseudonymized data, we have a new option that's appeared on the top, send data to Primus, and you would click on that. Because I've got a couple of audits open here, it's asking me if I want to send them all. So I'll just say no, I just want to send that one. And then you get a couple of warning messages. You're going to send data to Primus. Are you sure you want to do that? Are you really sure you want to do that? And then this will show you the data string, basically. And all it's showing you is we're not sending any patient-level data. We're just sending these fields and these totals. That's all that's going. And at some point, it will then ask you to log in. And that would be your Primus Hub username and password, which is just a free registration on our website. It's just so we know where the data's coming from. And it's as simple as that. And it refreshes in Chart Online overnight. I'm not sure how often it goes through to your AF dashboard locally, but I know that the NHS England will look at the Chart Online data as well. Just jump back to here. Now, I did say there's a lot of data in the data sheet. So I've just listed the sections that we've broken it down into. So we've got the demographics right at the beginning, then all your diagnosis information. So we'll look for their earliest and their latest AF diagnosis, so you can see if it's changed or if it's the same. Because some of them are quite historical. We'll then look at their risk factors and their risk scores, and then all the medication sections. And you can expand these and collapse them as you want to. When I mentioned this instruction guide, right at the back in the appendices is a list of those datasheet columns. So if you want to just think, do they collect this? What's this column called? I would refer to this. It's a lot quicker than tilting your head sideways to look for the particular column that you want. But I believe you can do a Control F and just search through chart. You can imagine our diabetes set is really large. So that's just one way to do it. Now, we have a case finder as well, as I mentioned before, and that will categorise patients into these two areas, whether they've got probable AF or possible AF. And I think, was it you, Bruce, mentions about 1,000 patients?
About 1,000 on Wirral we don't know about yet.
Okay, so this will help you hopefully find those patients. Just out of interest, did you run the case finder? And no. We usually say try and run it before GRASP AF, but that's just a personal thing. It just ensures that your register and your prevalence rate is as accurate as possible before then looking at the care of those patients. So it'll just do a quick run through and look for all of these different things, and then it will present them to you. That is the AF case finder dashboard. But really what you want is the data sheet underneath. Which of these patients have got probable AF and which have got possible AF, and why is that the case? And you would just scroll across and look at the data that it's showing you. We've talked a little bit about Chart Online already. We've got toolkits for lots of different clinical topics. It's aggregated, anonymised data. Once you've uploaded, you can go into Chart Online and look at the data. So here's an example of one. And you will see your own practice identifiable by your practice ID number. But all the other practices in your CCG, you will see an anonymised practice number. If the CCG is granted access and there is a request process and it has to be approved by NHS England for them to get access to this, and that's just to verify that it's a genuine request and genuine need, they will also only see anonymised practice numbers here. But you can grant them access to your practice ID should you wish. So it's all in your control. So, sorry, just to talk you through this graph, this is within our Chart Online area. It's looking at AF prevalence for each practice. So each of the blue bars is a practice within a CCG, and the red triangles across the middle are the average for the whole of the data within Chart Online, of which there is quite a lot. I've got some figures which I'll share with you in a moment. So you can see the practice on the left where it's quite high. They are massively above average in this particular area. It might be genuine. They may have an elderly population or what have you. It's just showing you the variation across the CCG. The practices on the other end are lower than the average. It might be that they just need to do a bit of case finding work, or it might be that that is legitimate as well. Looking at the treatment graph that I showed you before, so are they on both antiplatelet and anticoagulant, or anticoagulant alone? You can see that generally across each of these practices, it's around about the same, with the exception of 2, which are completely red. And that's saying that of all the patients with AF in this practice, none of them are on an anticoagulant nor on an antiplatelet. So you could then think, well, what am I doing different to everybody else if that was your practice? Hopefully not. We have 3,755 practices across England that downloaded the tool from 206 CCGs, so it is quite well used. I'm just going to talk to you now a little bit about warfarin patient safety. So this is another one of our tools. This one, it was funded by Boehringer Ingelheim. And it looks at anybody on warfarin for whatever reason. They might be on it for AF, they might be on it for something else. So it just lets you assess whether they're achieving maximum benefit from their medication by calculating their time in therapeutic range, which someone has talked about already. So it looks at your INR results on your clinical system, and it calculates TTR for you. And then it identifies those with some out-of-range INRs, and it does the has-bled calculation for you as well, so you can assess whether the benefit of anticoagulation outweighs the risk of their bleed. So again, it's a similar kind of feel. As I said before, once you've got used to one of the tools within Chart, they'll all start to feel pretty familiar. You've got your data sheet view. And what you can see within the data sheet is their TTRs over the last 12 months, last 6 months, last 3 months, over here. So you can see in this patient, last 3 months, they're a TTR of 100%. It drops down to 86 when you look at the 6 month period, 87, sorry, and then 76 over the last 12 months. But some of them go the opposite way, so it's actually quite interesting information. I'll show you what the report looks like, because it looks quite different to GRASP AF in that it's not a dashboard. It's a narrative report designed really just to talk you through your results from your practice. So it tells you a bit about the aim of it, how many patients you've got and how many have had an anticoagulant prescribed in the last 3 months, how many of those were warfarin. We're still calling it a NOAC in here, but how many were a DOAC? These patients have to have been established on warfarin, so not just recently started, they have to have had it in the last 3 months and within the previous 6 months to that. So over a 9 month period, they have to have had it at least twice. So it will exclude those who've recently started. So we know from the research that patients with a TTR less than 70% aren't getting maximum benefit from the warfarin, and those under 40% are really getting no benefit at all and actually potentially at risk of harm. So we've got 9 patients here in this practice who fit that category, and 47 who really aren't getting the best. And then it tells you what your action is. You need to look at these patients in red and then figure out why their INR is not stable. Out of range INR, so those greater than 8, greater than 5, or more than 1 unit below their target. And we calculate the target based on the reason they're on warfarin, so we know usually what their target should be based on the reason that they're on it, unless you've actually entered a coded target INR, in which case we'll use that. And then the has-bled, I mentioned. Oh, sorry, you can't see what I can see. I should have said. Sorry. Well, I don't know why. Oh dear, okay, sorry. Yeah, but then there's a table that shows you the has-bled versus, I didn't do it, I was thinking for that one. And then it'll basically tell you who's had a warfarin assessment in the last 12 months. Okay. I can't see what you're looking at now, so I don't know what's happened here. There's some preset filters within warfarin patient safety again, so you can quickly get to these patient lists. Those with a TTR less than 40%, as you can see. And those with no identified reason for being on warfarin, so we know they're on it, but we don't know why, so you could make sure that gets entered. And again, it's got a chart online toolkit. So this is just looking at TTR bands. So the ones you're really interested in is the practice on the right has nobody whose TTR is greater than 70% over a 12-month period. They're all got middle and low range. This one is just looking at number of INR tests in the practice. So you can see there's great variety across the CCG here between the number of INR tests being done. Sometimes it's a case of the fact they're being done in software such as INR Star and not being imported into the clinical system. And people don't know that that's a function that you can actually do. I think I've covered some of these IG assurances. So we don't collect patient identifiable information. Sometimes practices are understandably wary about uploading data anywhere. So I just wanted to reassure you that we are strictly governed by the university's IG policies. We now have the NHS IG toolkit compliance on all the ISO ones. So, but it's your decision. But I don't know, is it within your LES that you're going to ask that it is uploaded. It needs to be uploaded. And so I think as part of the support and training package, for that initial baseline run, which we will do on your behalf, we will obviously talk to you about uploading that first set to Chart Online. Because in order to look at where you are on the Wirral in terms of, you know, your very first starting point, it's really important that you upload that data regardless of how good or bad you think your results are, because it's about where you're going to be in 12 months' time. And you can't really demonstrate the outcomes that are needed without doing that. It's really important, obviously, to have your practice patient-level data, but it's also really important to have that CCG and national-level data as well. And NHS England are doing a lot with that data in terms of care planning and service provision as well, so it is really important. I think that's it.
That's good. Okay. Thank you very much.
Thank you.